Good evening, everyone, and thank you for joining this webinar this evening, which is Osteoarthritis of the Knee, What Should I Do? My name is Dana Harris, and I am a PHN Education Officer, and I'll be facilitating tonight's session. I'd like to start by acknowledging the traditional custodians of the land that I live and work on. Today, I am on Kamilaroi Gomeroi land and pay respects to their continuing culture and contribution to the life of the vast region. Before I introduce our speakers for this evening, I just want to let you know of a few things. This session will be recorded, and the recording and PDF of the slides will be available on the PHN website in the next couple of days. As attendees, your camera is automatically disabled and the microphones will automatically be muted. If you do have a question or any comments to make during today's presentation, please send those via the chat box, and Gemma Modell will answer on our panel tonight. We'll answer them. Thank you, Gemma. After this evening's sessions, an evaluation slide will come up with the learning outcomes. It would be grateful if you could please answer those for us. It is now my pleasure to introduce tonight's speakers, Claire Doherty and Gemma Modell. Claire Doherty is an Order of Australia Medal recipient and is the Senior Outpatient Physiotherapist at Tamworth Rural Referral Hospital. Gemma Modell is currently working as a Health Services Manager for Community Health and Allied Health in Armidale, and she's worked as a physiotherapist in Armidale Rural Referral Hospital for 35 years. Thank you for being with us tonight, Gemma and Claire. I'll hand it over to you now.
Thank you, Dana. I was to unmute myself. Okay. Thank you, Dana. Thank you for having me come tonight with the opportunity to speak about osteoarthritis. It is something I'm very passionate about. So tonight we're going to be talking about the conservative management of osteoarthritis, the non-surgical and non-pharmacological. I've always said that in health is the ultimate team sport, that when we can work together and coordinate care and get our resources allocated in a timely manner, then we really can provide optimal care for management of osteoarthritis, looking at reducing the severity of the disease and managing it well. So tonight, pretty much, I just want to talk about getting us all on the same song sheet and finding out what all our roles are and get them coordinated. All right. Excuse me for a sec there. So the first slide is from the National Osteoarthritis Strategy, and I think it sums up really well the key principles in the management of osteoarthritis. Prevention, which has to be the cornerstone of every chronic disease, we're not going to really touch on tonight, apart from to talk about, obviously keeping a healthy weight. You're 4 times more likely to get osteoarthritis if you're overweight or obese. Keeping fit and strong, and also to reduce the number of ACL injuries, which has increased tenfold in our youth, particularly with our women. And we know that within 10 years, once you've damaged your ACL, whether you have it repaired or not, 80% of those young people will end up getting some early osteoarthritis, which will likely progress. So the main focus for tonight is going to be, as it should be with all chronic diseases, which is living well with your condition, and looking at putting resources into that area, so that if and when it comes to a time of advanced care, then we can start to coordinate when is the best time to look at advanced care. So osteoarthritis is a very common condition. It involves pain in the joints, loss of mobility, and affects your quality of life. Depending on what statistics you read, it's very prevalent. They say probably about 1 in 5 people over the age of 50 have osteoarthritis of the knees, and that goes up to about 30% when you get to over 65. 2.1 million Australians, and they say that's going to blow out to well over 3 million by 2030. It's a very common reason that it visits the GPs. You'd be aware of that, and it's a very expensive healthcare drain. So from 2002, the Australian government said that it was a national health priority, this epidemic of osteoarthritis. They could see it coming, and that's largely driven by the ageing population and the upsurge with obesity. Now you can see on that graph, which is a graph of total knee replacements. On the y-axis is the number of knee replacements, and the x is the year. The filled in line is basically the sum total of all age groups, and you can see that there's been this massive increase in the number of total knee replacements that are done. It's increased by a good 50% in the decade from 2005 to 2015, and they predict it'll go up to close to 300% by 2030. And we know that we're not going to be able to sustain services for such a number of knee replacements. At present, we're really struggling. Now, most of the cost in osteoarthritis is hospitalizations to do with joint replacements. Joint replacements are more expensive than any other healthcare procedure in the hospital. So you can see we're struggling as it is now with 60-odd thousand knee replacements. So once it gets up into the hundreds of thousands, we're just not going to be able to cope with that. So all around the world, they've developed guidelines. There are so many guidelines. There's more guidelines with osteoarthritis than anything else I've read. The only second to that is Indigenous in Health. And all the guidelines say the same thing, that there's a crisis, that if we don't get on top of this and start to look at optimal management strategies, then we're not going to be able to cope. So they've got together all of the guidelines, including the RACGP guidelines, have built a pyramid of treatment, which is the best practice for osteoarthritis. And you can see on the bottom, the first line management is education, exercise, and weight control. And that should be offered to everyone, regardless of their severities, regardless of their age. And then the second tier is second line management. And that's the management that most of my patients, that's all they want. They want the hot packs and the massage and the electrotherapy and the tape and maybe some needling. And we know that that's not as effective as the first line management. It should not be introduced before first line management. And in that comes pharmacological pain relief. And then the last tier, which should only be offered to a few at end stage osteoarthritis, which is joint replacements. And it is the gold standard for end stage osteoarthritis. So I'm very keen on having knee replacements at the right time. But the problem is somewhat we've inverted this pyramid. So we know that there's a pyramid and that you should be offering everybody first line management. I think we all understand that. And few should be getting knee replacements. But unfortunately, that's not what happens in the clinical world. We have this practice gap, which is present in many areas of health, that 3, 4, 5% of people are offered physiotherapy, 10% exercise, 78% are offered medications. And this is early in GP consults. This is the Beach study. And then when you look at the osteoarthritis waiting lists for people waiting for joint replacements, and they've done an enormous amount of audits on those, only 10% have been offered exercise. And I find that with our waiting list, if you ring around and find out, has anyone been offered exercise, have been offered physio, it's 5-10% of people. You're more likely to have been given an orthopedic consult and some medications. So what happens that I see is that people just sit on very long waiting lists, probably a year to see the orthopod. This is the public sector. And then probably another year for a knee replacement. And in that time, they're getting weaker. They're often putting on more weight. They're avoiding activities. And that gets into a cycle of ill health. And we do know people with osteoarthritis, they do suffer worse health outcomes. They have more comorbidities. Twice as many people report their health as poor. 50% of people with osteoarthritis have depression, and it is depressing being stuck on a waiting list, thinking that the only fix is going to be a knee replacement. Now, what does good high-value healthcare look like when it comes to management of osteoarthritis? And I have seen some good high-value healthcare with osteoarthritis. This is a project that's been run by the Osteoarthritis Chronic Care Program. And let me just show this video. If it's not loud enough, please let me know.
Leading better value is about the patient as part of the decision-making process, and to inform them on the problem, what can be done to help, supporting the patient to more effectively manage their osteoarthritis.
The spectrum from early disease to late disease, there is this whole area of the mill which is not managed in a very consistent manner. And so we certainly saw a need and value in trying to produce a service to give patients the ability to access good, consistent care to get optimum function. And all of a sudden, you get a patient who's got a painful minor arthritic knee to a painless minor arthritic knee. So in terms of the arthritis, that hasn't changed. The function is dramatically improved.
I was quite enthusiastic from the outset for several reasons. One is obviously to see the patient benefit and the clinical benefit to patients, but also the integrated care really appeals to me, the idea of actually GPs and the primary health network and the LHD and specialists and hospitals actually working together to get a result and communicating with each other. It's undoubtedly the way that medicine should be moving to. In the past, management of these issues has been mostly symptomatic. It's often would only try pain relief, and if that didn't work, then possibly referral to an orthopaedic surgeon to discuss joint replacement surgery. But we now know there's a lot of other options without going down the line of joint replacement surgery too soon, or without giving other options a trial first.
We started this program as a pilot, trying to identify, well, is this something that we can improve in this space, become both an effective service that will provide a lot of value for the community, as well as minimise specialist intervention in early phase when it really wasn't required.
Sometimes communication is the best way to get simple changes like this, simple but effective changes across the line.
Well, I've had problems with the knees for many years. Not able to walk really well, and I was also taking a fair bit of medication for the pain. I refused to have an operation, but I wanted to be able to stay in my own home. And so we had to look for other options, and this seemed like a good one. Everything was sort of getting worse, and I started falling, or my knees would give way. That was horrifying, because until you've lost confidence in something you take for granted, like walking, you don't know how inhibitive that can be. And now I don't need walking sticks. I am confident that my legs are doing the work.
Of the patients that have been through the program so far, 2 out of 3 have reported that their pain has improved, or their knee or hip function to have improved, and 2 out of 3 have reported that their walking has improved. So anecdotally from my patients, I'd say at least probably 3 out of 5 of my patients have avoided or declined surgery, gone away from the surgery path.
I have so much to thank the program for. How do you say thank you when something's given you your freedom, your confidence, your life back?
Fabulous. I'll just close that down. I think I might have disconnected you. And excuse me for a second.
You're all good. You just have to go back into the PowerPoint.
Sorry. Okay.
Down the bottom.
Yep. No worries. Sorry. Just go to.
And if
slideshow. That's beautiful.
there
Sorry.
we go.
Be a bit of an idiot. So that program looks fabulous, doesn't it? We don't have it here. It's part of the Leading Better Value Care program, and it's called the Osteoarthritis Chronic Care program. So I've been looking at this osteoarthritis space for a very long time, and this came out about 2011. And up until COVID hit, they'd been working on collecting data and trying to build integrated care and lots of communication. And it says on this website now it's been rolled out through all local health districts in New South Wales. Well, we don't have it in Tamworth, but I have seen it rolled out in areas, St Vincent's and Tweed, Royal North Shore. And the key to that is if you've got a project manager and you've got some resources, then I think we can roll out these sorts of programs, but we don't have that, unfortunately. But I love the idea. So I think this is something for the future, that we should be able to link in more with this Leading Better Value healthcare. So the goals of the Osteoarthritis Chronic Care program, I love. It's exactly what first line management should be. It's what high value healthcare should be. We should be teaching people to understand how to manage, self-manage OA, understand, get confidence, improve their pain, function, quality of life, get them moving more, get the activity levels up, reduce or remove or delay the need for surgery, get better access so patients needing surgery don't have to wait for 2 years before they're eligible, and then to get better outcomes for patients for surgery. I was talking to an orthopedic registrar last night, and his advice to me was, he says he tells patients to do everything possible before you need a joint replacement, because it's not without risks and there's so much you can do. So his advice when I was chatting about this, he said, well, just make sure people know they've got to do absolutely everything possible. But then, you know, how do we give everyone these amazing programs without any sort of funding? So they don't roll themselves out, that's for sure. So I've found quite useful this thing called the Osteoarthritis Clinical Care Standard. Now this helps give you a framework. It's 7 quality statements. It's a really fabulous document, and it tells you what you should do, and very importantly, when you should do it. So this is something I share with all my patients, so they learn exactly what stages we're going to go through and how we're going to go about this management plan. Now, if you look at the number 2 for diagnosis, so I'm just going to bring that up because I think that warrants having a look at, because this is one of the issues I find tricky. It says here with the diagnosis that a patient should be diagnosed basically on a clinical assessment alone, that x-rays are really only considered if you suspect that there's some sort of red flags, and MRIs, again, if you've got suspicion of serious pathology. Now, I really understand it's a very difficult situation. It's all very well for me to say don't scan anyone. I do understand that you've got to be able to screen for red flags, but if I could get one communication across, is that it's really hard then to shift people's mindsets. Once they have an x-ray done, they're fixated on those images, and we do know that images don't correlate really well with osteoarthritis outcomes, particularly not until very end stage. And that if you look at, you know, hundreds and hundreds, if not thousands, of pain-free people over the age of 50, 50% of them have asymptomatic findings. So we know that imaging does tend to over report pathologies that may or may not be symptomatic. And once the person has that belief, it's really hard to change that. So that'd be my only particular feedback about the imaging. It gets you on a train ride to somewhere often you don't need to go, or you're getting there too early. So the diagnosis for osteoarthritis is a clinical one, and if you look at 2 different guidelines, one's a European rheumatology group and the other one's an American radiology group. So the European one pretty much says that you've got to have knee pain, early morning stiffness, less than 30 minutes, or no early morning stiffness, and some sort of functional limitation. You need crepitus, loss of range of motion, maybe some bony enlargement. Whereas the American radiology one says you've just got to have knee pain and a few of the other ones. So basically it's knee pain with a restriction in movement. You're not too stiff for too long in the morning, and you've usually got some crepitus. So in order to make a change, to get services up and running, to be able to provide the primary care with the services they deserve, which is to be able to refer people off early to effective exercise classes, we've got to build that capacity. And I've worked in health for 35 years, and when I looked into getting some exercises up and running, it's always so difficult. There's always so many barriers. When I started looking at this, the only other group doing exercises in all of Hunter New England area health was Armidale, and so I thought, well, it's not easy to get exercise classes up and running. So rather than reinvent the wheel, I looked around what was the very best program I could find, and I found a lovely program. This has absolutely changed the way I treat osteoarthritis, and it has changed the lives of literally a couple of hundred people in Tamworth. Now, it stands for Good Living Arthritis in Denmark. It is a really solid, evidence-based, structured exercise and education program. It's really effective, it's feasible to roll it out, and you get really fast results. You get 12 supervised exercise sessions with 2 education sessions, and part of it is data collection. The objectives of the GLAD program align absolutely beautifully with the objectives of the Osteoarthritis Chronic Care Program, which is basically give everybody access to high quality first line management, to try to reduce surgery and to really only consider it once we've exhausted all non-surgical treatments. And in doing that, we're going to have fewer people visiting our health services, particularly at the pointy end where it costs so much, which is all your knee replacements. So we know exercise works. It works better than paracetamol, than non-steroidals. It works better than PRP. At this stage, it works better than stem cells. There've been over 60 RCTs saying that exercise is effective. It is safe for osteoarthritis. So that's a given. We don't need to do any more studies. That's one of the Cochrane pieces of advice, is no more studies on does exercise work. We know it works. And it works so well that these are some of the outcomes. So this is one of the good things about being part of something like GLAD, and I'm not saying everyone should be part of GLAD, but I've chosen to be involved, is that you're part of data collection. So from the 2020 GLAD summary of outcomes in Australia, we found some good demographics. So 48% of people over 65, 72% are female, which is what we find across the board, 3 out of 5. The average BMI is 29.9. Now, this is so amazing. After 6 weeks of twice a week, the average pain was reduced by 36%. Quality of life is improved by 25%. Sit to stand test in 30 seconds improves by 30%. Sometimes I find that improves by 100%. I've got some people in my classes who could get off the chair in 30 seconds 3 times, and by the end of the 12 sessions, they're getting off the chair 10 times or 12 times, which is amazing. So these are real clinically meaningful changes. 3 in 4 people say that their quality of life's improved, and this is fascinating. When they have asked people who are prepared to have a knee replacement at the beginning of the class, in the assessments, at 1 year, once they finish the GLAD program, and it only goes for 12 sessions, so it only goes for 6 weeks, 3 out of 4 people, and I assume they've kept up with their exercises, have said that they no longer desire surgery. They're going to wait a little bit longer and see how they go, and that's just phenomenal results. So this graph, this picture here just shows you, again, that summary, that 33% improvement in knee pain. The GLAD program also targets hip osteoarthritis, so it's very valuable. And most people have multiple joints. They've got hips, they've got knees, they've got hands. Medication reduced by 47%, quality of life by 31%, it goes on. So it's a very effective program. The testimonials are always amazing. The buzz in the room is incredible. And you can either do this as a home program or as a group exercise. And I love the group exercise. The dynamics are very powerful. People say it's been a lifesaver. You know, they didn't realize they could exercise. They thought they would damage their knees. They feel like they're getting stronger. So many people say they're now taking the steps. People report their balance is so much better. So initially when I started doing the program, I thought, look, don't worry about the education. Let's just get into the nitty gritty, which is all the exercise. That's what it's all about. But I soon learned that you won't get anywhere without the education, and that's true of all chronic diseases. People need to learn how to manage what is the disease and how they're going to manage it. Now, this first bit with the cross on it took me a long time to get my head around this. You can't say wear and tear. We've got a swear jar for wear and tear. You've got to put $1 in it. That you can't say that osteoarthritis is a disease of aging. Plenty of people get older and don't get osteoarthritis. It is common with aging. And our traditional view is very X-ray centric, very cartilaginous centric. But now that we understand that osteoarthritis are structural changes in the whole joint, the meniscus, the cartilage, the subchondral bone, the synovium, and the muscles. And there are many things that contribute to pain in the knees, and one of those is physical inactivity. So this slide I find very helpful, and all this stuff is part of the GLAD program, so they make it easy for you. They give you all the educational material. So people really resonate with that. There are many reasons why you'll get disability and pain in your hips or knees. Some of it's your X-ray, some of it's weight, some of it might not be sleeping well or not getting enough exercise. Muscle weakness is something people really understand. It's very tangible. Injuries to your knees. A lot of people will say, yeah, they hurt their knees playing football, so they can understand, well, that's going to contribute to my osteoarthritis. This one of stress and isolation, this has become so common. I'm sure everyone in this webinar will agree with this, that people are so anxious, they're so isolated, they're so stressed. I have many people who just want to come to the exercise classes because it's a social outing. And the last two slides are about, the last 2 points are beliefs. Like, it's so powerful. People have this belief that their knees are very fragile, and if they go up the stairs, they won't be able to walk for a week, and how they're going to cope. They lose confidence in their knees, and this is very depressing. They no longer can do the things that really give them joy in life. Shopping, socializing, going for walks, walking the dog. We talk a fair bit about the facts and the myths, that scans, they often over-report that up to 30%, 20% of people don't get relief with knee replacements. People think they're going to get this Ferrari knee and they end up with a bit of a V-dub. It's really, really common. And they're going into surgery often not fit or not strong. That rest and avoidance will make your pain worse, that exercise is safe. And this point that pain does not equal damage is very true. I had a chap yesterday telling me, he did 10 sit-to-stands and he couldn't walk for a week. And I have to reassure him, it's not doing your knees any damage. Your knees have got sore. They're not stuffed. They're going to get sore. Your knees aren't used to that loading. So we're able to give him a loading program and get him safely so he can feel that he's confident to strengthen up those knees. That the degree of arthritis doesn't predict your pain and disability levels. Some people have terrible arthritis on x-ray and they have very little pain or disability, and vice versa. This idea that only surgery will fix it and that our exercise is dangerous. So just reinforcing, letting people know that, your body is robust. It takes a dreadful lot to damage joints. People often think that their knees are going to collapse or their hips are going to collapse, particularly if it says on their imaging that they've got, degenerative changes and spurs. And of course they worry the spurs poking into something in their hips so they don't load that joint properly. And then that underloads the joint, which will contribute towards pain. So I've really worked on getting absolutely every single person getting their activity levels up. People who say they can't walk because of pain, we build it so that they can at least get up to 70 minutes a week, and that's going to be enough to reduce your blood pressure and help with weight and depression and a whole bunch of other comorbidities. This slide here I find very, very useful. So the top bit's got a picture of regeneration and degeneration, that as we get older and with weight, our bodies get tipped into degeneration. We're constantly in a state of growing and breaking down. The only thing, there's no pill, there's no ointment, there's no injection that's going to tip us towards regeneration. The only thing is exercise and, if appropriate, weight loss. And that's very empowering. I say you can make a change. Even though cartilage doesn't change much after being a youth, you can make it healthier. I try to replace the words like wear and tear with motion is lotion, and wear and repair. That every time you do some strengthening exercises, you release a little bit of a thing called lubricin, which is a synovial fluid into your joint, and it'll lubricate that joint. When we exercise, we increase our stability and our joint function. Exercise helps us feel better and helps us more confident. And at the end of the day, even if you don't get rid of your pain, I say to people, exercise is good for you. It improves 35 chronic conditions, and that very few of us get our recommended guidelines, which in the older age group will be 75 to 150 minutes a week and twice a week, building strength, bone density and balance. And I incorporate that all into my GLAD program. So there's two different types of exercise in the GLAD program, and that is neuromuscular exercise, and that's looking at control and alignment. So not just the strength of the muscles, but also how you load those joints, what alignment you load those joints in. We use a pain scale to let people know it's acceptable to have an increase in pain. I often say, when you used to play footy or tennis, of course it would be uncomfortable doing some exercises. You'd often be uncomfortable the day after. But it's quite acceptable to have a small increase in pain, 2, 3 out of 10 increase in pain. But if you're getting 5, 6, 7 out of 10 increase in pain, then we're probably just over-exercising you. It's not the worst thing in the world. It's a bit like Goldilocks and the porridge, if you're underload, it's not good. If you're overload, it's probably not good, but it's not going to cause any damage. We've just got to get that dose right. The one I really max out is I talk about strength. People can understand it. It makes sense to them. If you can get stronger muscles, then you're going to take the load off those joints. The main muscle really is going to be your quadriceps. We know that from the studies. If you can build up your quads, the chance of slowing up those arthritic changes on x-ray becomes much higher. And you can start to then mitigate some of those non-modifiable factors in osteoarthritis, which is your sex and your age. So the two big ones really are targeting obesity, I think, and your muscle strength. Here are some of the pictures we use of the exercises in GLAD. Very simple. You don't need any fancy equipment. We just use elastics, some chairs, some beds. So that's pretty much what the GLAD program looks like. Now, unfortunately, the OACCP didn't want to use the GLAD because OACCP is multidisciplinary, but I see it as a really fabulous way to get the education and the exercise component. And we do talk a bit about weight loss and say that, you know, if you can reduce 5% of your weight, that's what we aim for. It's about a 30% improvement in your symptoms. If you can get to 10%, it's going to be about a 50% improvement. Now in Tamworth, we don't have any capacity really for any outpatient appointments for dietitians, but every day there's more stuff coming up online, and you know, maybe that's going to be something for the future that we might be able to link in with some sort of online, pardon me, platform. I think that works really well for things like chronic pain and probably for dietary advice. So in summary, you know, we want to be providing to our primary healthcare sector this really high value patient-centered care. What it looks like is the video clip from the osteoarthritis chronic care program, but we don't have any money for that. So I think the exercise education component can be done in some sort of structured program. I'm using GLAD and finding it very exciting. As I say, we've had a couple of hundred people go through it. In a class of 6, I find about 2 tend to say that they're happy just to manage their arthritis, and then we offer them some options for following on in the community. I think it's good to remember that we've got this pyramid. If we can try to coordinate our services by following the care standard or this pyramid, then hopefully we'll be able to reduce this epidemic of knee replacements, which is increasing every single year, and be able to put our resources more into living well with these chronic diseases. And that's pretty much me with a few things for future directions. So I'll stop sharing that now. All right, is that back to you?
It isn't yet. I can make, Gemma, are you happy for me to make you the presenter now?
Yes, please.
Here we go.
So you don't have to remember everything Claire told you because it's all on My Health Pathways, which is amazingly good. Now, I don't know quite how to get to the top of that. Yes, I do. I'll try and move that out of the way. So I'm hoping everybody's aware of My Health Pathway, and it's got fabulous resources, and all of this stuff is right there. So I've gone straight into the knee osteoarthritis section, and it talks immediately about the red flags. So if you've got those red flags, then maybe you would be considering some imaging. And then just going, oh, sorry, I've gone a bit too quickly there. Reiterates everything Claire's just told you, that really imaging is probably not the be all and end all. You can use your clinical skills to diagnose. Weight loss and exercise are the most significant sustained effect on pain. And about 70% of knee replacements are carried out on patients whose weight is significantly contributing to their OA. We really need to focus on that weight a little bit. I'm sure you'll know how to take a very good assessment and history. Does quickly touch on a few differential diagnoses within there, and my thoughts are you probably want to refer to a physio anyway for half of those things. You could do the Oxford knee score if you chose to, which would also give you a bit of an idea of where they're at with their arthritis. But again, imaging is only a part of it, and really once you get a bit further into it, and the preferred imaging is in fact weight-bearing X-ray. It's way more preferred over MRIs unless you've got some other suspicions of something really serious going on. And the orthopaedic surgeons actually want weight-bearing X-ray, just a plain film. They don't really want all the fancy stuff generally. Again, it does just go across some of the diagnostic criteria for you. So pretty much anybody over 50, you're looking down the barrel of possibly having sore knees if you're not doing enough exercise, or if you're doing too much, like some of us can do. And that covers all of those same things Claire has just said there. And exactly the same, overweight people have double the risk of developing knee OA, and that's part of why we've got this massive wave of people coming towards the orthopaedic surgeons wanting a total knee replacement. We need to try and get the weight down and just get them exercising a bit more. Breaks it down now into the non-pharmacological pain management, which is about exactly the same things that we've talked about, educating. There's actually some really good resources though as well. Oh, sorry, and I hope that's taking you to the correct place, but there's other places that you can go to. So the musculoskeletal website, that's got a lot of support, and then I think that's just the arthritis one as well. And again, if people aren't into coming to classes, don't want to go and see someone, they can get a real lot of information just from these resources here. One of my bugbears is what people say about arthritis. The old wear and tear is not really a good thing, as Claire said, and that some people catastrophize their pain a bit. Try and get them into, you know, being resilient, trying to do their weight loss, get a bit of exercise going. I'm not sure I like this one about your scans are normal like grey hair, but more so, what I was a bit concerned about is, sorry, I'm not very good at driving my mouse. The bone on bone. The number of times I've heard patients say that, I've got bone on bone, and as soon as they hear that, they are immediately terrified to do exercise. So we really need to move away from that language. That's one of the things I can't stand people saying. Their knee might be weak, but we just need to encourage positive things, and that, you know, this, to a degree, this is normal, and you know what, we can reverse some of that. Planned physical activity and exercise for all patients is, regardless, I think all patients should be getting physical activity and exercise almost no matter what they've got. So then further down, I think we do have, yes, and so this is the section I was trying to get to for you guys, and I'm not quite sure where everybody's from here, but you can link in and find where some of these programs are, because I understand that a big part of GP's life is, well, where do I send these people to? So again, we've got all of these, it lists all of the physios, and I did notice, so I've rung, and I know that, and I'm sorry, there's lots of physios around, so I couldn't ring all of them. I know the New England physio has done the GLAD program, I'm pretty sure, and somebody in Tamworth has as well, which is mentioned here. And I'm sure I found that somewhere. Here we go, the GLAD. I did ring them, and they're not doing the classes just yet. Unfortunately, COVID's still messing people up a little bit. But most of the bigger practices have got exercise classes. I know Move for Life has got a couple of really fabulous classes that people can go along to as well. So that's all the private physios, if you're able to forward there, and then again, the public physios. In our neck of the woods, Armidale Hospital definitely has a program, and again, unfortunately, we stalled across COVID, but we're looking to ramp back up again. We're hoping we get a few referrals from this. And Inverell is also looking to recommence. I know Claire is continuing on with hers, and she may mention other facilities out that way that are running.
Manila's got a class up and running, and
Okay.
Barraba's about to start theirs, because I think there's about 20 or 30 odd people in our region now trained in GLAD. So it is a matter of talking to your general practitioners and the primary healthcare network, and just seeing if you can get these classes up and running.
Someone's just made a comment in the questions box. So Elizabeth Ward said that they've got a GLAD program on the Central Coast at North Gosford. In fact, if you go onto the GLAD website, you can look up where the specific GLAD programs are. Some of us have done the GLAD training, but don't necessarily link in and do the retraining year in, year out. And GLAD are actually not too upset by that. But I don't know that you can call yourself a GLAD program unless you keep doing the refresher and pay money each year. But have a look on the GLAD website, because that also has a lot of really good information. Look, referrals are fairly standard. We just take them through e-referral. Ignore the My Aged Care portal. No, none of us take it through that. I'll try to get somebody to fix that up. all the normal things that we would want, and we tend to take it, I'm sure it said, yes, so just the e-referral, sorry, I was trying to find that part for you. Here we go. E-referral, and in fact that fax number really is sending it into an electronic system. So each facility does talk about what how you can refer on into these different areas. Apologies, I'm not too sure what these guys have, but I'm sure if you go in you will find loads of stuff in there as well. So that was all I wanted to show from my end, just so that people were a little bit more familiar with my health pathway and being able to refer to the appropriate place. And it's got all the information there for you. You don't have to remember anything we said. You just go onto my health pathway. Was there any questions from anybody?
Excellent. Well, thank you so much, Gemma and Claire. If there are any unanswered questions at the moment, if we want to just put them into the chat box. Give us a second. Look, if there are any unanswered questions at all, please feel free to email them through and we can get Claire and Gemma to answer them as well. So thank you so much again, Gemma and Claire. If anybody doesn't have Health Pathway logins, I will make sure that I send it out tomorrow, and also send the direct link to the knee osteo, not knee replacement. Oh my goodness, I'm so sorry. Osteo. I'm so sorry. The osteoarthritis knee plate will be sent through tomorrow. Now we will have a short evaluation pop up, and if everybody could answer that, that would be fantastic. A recording of tonight's presentation and a copy of the slides will be available on the PHN website in the coming days. But if there's no more questions, it doesn't seem to be. No worries. All right then. No worries. Thank you everybody so much for coming tonight. We look forward to seeing you at our events in the future. Thank you.
Thank you, Dana.
Good night.
Thank you, everybody.
Thank you, Claire.
Thanks, Gemma. Thanks, Dana. Thank you, everybody.
Bye.